Swayam Prabha. Digital India. Educated India.
Hello, I'm Dr. Medora Dias from Goa Medical College and Hospital, and today's topic what I'm going to present for you is histology of the liver, gallbladder and the pancreas. Some clinical aspects that we are going to talk about: cirrhosis of the liver, gallstones also called cholelithiasis, pancreatitis which is an inflammation of the pancreas, and adenocarcinoma of the liver, among other things. The liver. It is a reddish brown gland situated in the right hypochondriac region of the abdominal cavity just under the diaphragm. Grossly, the liver is comprised of two lobes, a right and a left lobe, divided by a falciform ligament. And if you look at the undersurface of the liver, you can see another two lobes, namely the caudate and quadrate lobes. The liver is a gland having both exocrine as well as endocrine functions. If you look at the color of the liver, we say reddish brown because it has a large amount of blood circulating through it at any given time. The blood supply comes from the hepatic artery and the portal vein. The hepatic artery brings oxygenated blood to the liver, whereas the portal vein brings blood from the intestinal tract, very rich in absorbed products of digestion as well as in RBC products of breakdown like bilirubin and iron. If you look at the vessels in the liver in this figure here, this is a cut section of the liver showing you a site at the lower end where the vessels enter and leave. And these vessels, when they enter the liver, break up into 17 to 20 orders of branches. This blood is ultimately drained via the hepatic veins into the inferior vena cava. Through its blood supply, the liver can perform many functions. For example, it is involved in metabolism functions of carbohydrates and proteins. It is also involved in the excretion and secretion of bile. It is also involved in the detoxification of certain harmful substances that enter the body, like drugs and alcohol. There is a site at the inferior surface of the liver. If you see in this diagram, it's called the porta hepatis. Porta is like a port. It's a site where structures enter or leave. At the porta hepatis, what are the structures that enter? The portal vein, bringing blood from the intestinal tract, the hepatic artery, bringing oxygenated blood to the liver, and nerves. What are the structures that leave the porta hepatis? Structures that leave are the bile duct, draining bile towards the duodenum, as well as lymphatic channels. Bile is drained by the bile duct into a ductal system, the hepatic ducts, the bile duct, common bile duct, and ultimately goes to be stored in the gallbladder and is released on ingestion of a fatty meal. The liver is covered by a capsule which is called the Glisson's capsule, made of fibroconnective tissue which protects the liver to a certain extent, and this capsule fibers enter surrounding the vessels and divide the liver into lobes and lobules. Let's talk about the basic histology of the liver. 80% of the liver is made up of parenchyma and 20% is made up of stroma. So a large part of liver is made up of cells, the parenchymal cells, and a small 20% makes up the stroma, which is the fibrous content. The 80% of parenchyma is basically the cells called liver cells or hepatocytes. If you look at the figure here, these are the hepatocytes which are arranged in anastomosing and branching plates, resembling a three-dimensional lattice framework like bricks of a building. We said 20% is stroma. Stroma is basically the connective tissue element placed between the hepatocytes and other liver cells. Between the hepatocyte rows, you see these blue structures. These are the sinusoidal spaces which lie between adjacent cords of hepatocytes. The sinusoidal spaces connect to a portal vein at one end and drain into the central vein at the other side. Also present between these sinusoidal spaces and the hepatocytes are the bile canaliculi. The ones in green that you see here, these are the bile canaliculi, and they drain bile secreted by the hepatocytes towards the bile ductules in the portal regions. Also present in the portal region, you can see a branch of the hepatic artery which goes between the cells to supply them and drains towards the central vein. So this is the central vein here. And when we describe a liver structural unit histologically, we talk about the classical hepatic lobule. This classical hepatic lobule has got a central vein in the center and plates of hepatic cells radiating out from the central vein, and at the periphery you have areas called portal canals or portal areas which have a hepatic artery branch, a branch of the portal vein and a bile ductule. So this is what we were talking about, the central vein, the sinusoid, this is the branch of the portal vein, the branch of the hepatic artery, the bile ductule with a bile canaliculus, and these are the plates or the anastomosing cords of liver cells called hepatocytes. Here we can see a slide of liver stained with hematoxylin and eosin in a low power view. You can see the central vein in the center here and cords of cells radiating out like spokes of a wheel hub, and the peripheral hexagonal shape showing you one hexagonal classical hepatic lobule demarcated. And you can notice here at the periphery of the lobule you get spaces containing vessels. These are the portal areas or the portal canals. Now in the human liver, it is not very easy to distinguish between hepatic lobules because the connective tissue element is slightly less. But in lower animals, the connective tissue is much more, allowing you to demarcate hepatic lobules one from the other. If you look overall at the appearance here, this resembles a sponge in texture, a sponge wherein the spaces of the sponge resemble the sinusoids. Let's go to a higher power view of the liver. You can see here in this figure, this is the central vein. You can see radiating anastomosing cords of hepatocytes radiating from the central vein peripherally to the portal areas. So this would be the margin of one hepatic lobule. At the margins, you see here areas with vessels in them. These are the portal canals or portal areas. In the portal areas, you get a large thin-walled vessel which is usually the portal vein branch, and then you get some smaller vessels around it. You can see here one of the smaller vessels has a lining of cuboidal cells, and this is the bile ductule. So we see a portal vein here, we see a bile ductule here. These are also transverse sections of portal vein branches. Though we say portal triad is a misnomer, and I'll tell you why. Because a portal triad, if you think of the word triad, you would think of three things: the portal vein, the bile ductule, and the hepatic arteriole. But there are more than just three things in the portal triad. There are also the nerves and the lymphatic vessels. So actually there are 5 types of vessels in a portal triad or a portal canal. So we say that the word portal triad is a misnomer, because actually instead of containing 3 types of structures, it contains 5 types of structures. Let's look at a little more detail of these portal areas. There's a small space around these portal areas which is called the space of Gall. It's a narrow space surrounding the blood vessels and the hepatic ducts in the portal canals. We need to know how to differentiate the vessels in the portal triads. I've already told you that the portal vein is usually the largest, having a thin wall, and since it's a vein, it usually contains a plug of blood cells. The hepatic arteriole, on the other hand, is usually a smaller structure made up of concentric layers of smooth muscle and a very small lumen. The bile ductule is in between the size of an hepatic arteriole and a portal vein branch, and the bile ductule has a lining of simple cuboidal cells. In this slide, a little more magnified than the previous one, we can see the portal vein. You can see a small vessel here lined by smooth muscle cells being the hepatic arteriole, and in this one we can see a bile ductule. Here we can also see a portal vein. Notice the blood plug in it. So we see details of how we can identify the portal vein from the bile ductule and a hepatic arteriole. Again, in this figure we can see the portal vein, which is very large, it is thin walled, and it contains a blood plug in it. We can see a smaller vessel with a much narrower lumen, slightly compressed in this slide, with a lining of smooth muscle cells being the hepatic arteriole. Above here we can see a structure with a well-defined lining of cuboidal cells, and this is the bile ductule. So here we can easily identify the 3 different main structures found in a portal triad or a portal canal. And you see this space here. So this is the space of Gall, which is the space around the vessels in the connective tissue lining the portal triads. The central vein is at the center of a classical hepatic lobule, and blood drains into this central vein from the peripheral portal areas. So blood enters the hepatic lobule via the portal vein branch and the hepatic arteriole, and then it flows through the sinusoids towards the central vein. So here you can see the arrow showing blood flow, and the central vein will ultimately drain into larger sublobular veins which join together to form collecting veins, and these are ultimately tributaries of the hepatic veins. Hepatic veins, we all know, drain into the inferior vena cava, which carries blood away from the liver towards the heart. Let's study the functional units of liver. Here we see 5 classical hepatic lobules, and one of them has been colored in red for you to understand the hexagonal shaped hepatic lobule with the portal canals at the periphery and the central vein at the center. This is the structural unit of liver. The next unit is triangular. It's called the portal lobule, and we draw it by joining the central veins of 3 adjacent hepatic lobules and forming a triangle shaped portal lobule. It is defined as the area of tissue supplied by one branch of the portal vein and draining bile into a bile duct of that portal area. Another smaller unit of liver is a functional unit, the true functional unit, called the portal acinus or the hepatic acinus. It's a diamond shaped structure having a long axis joining 2 central veins and a short axis joining 2 portal canals. It is the true functional unit of the liver, and it is best for describing metabolic and pathologic changes in relation to many liver diseases. The zones in a portal acinus or a hepatic acinus, also called liver acinus, it's divided into zones 1, zone 2 and zone 3. Zone 1, you will notice, is very close to the blood supply. So, zone 1 cells would be most oxygenated and would have more storage of glycogen in them. Whereas zone 3, which is very close to the central vein, would have the least oxygenated cells, and hence this is the first zone of liver to undergo ischemic necrosis. Zone 2 is of course an intermediate zone lying between zone 1 and zone 3. Let's summarize what we have done today. We have spoken about the liver being an exocrine and an endocrine gland having 2 lobes, the right and left, and the quadrate and caudate lobes as well. The liver has something called the porta hepatis at its inferior surface, and through this many structures enter or leave the liver, like the portal vein, the hepatic artery, the nerves which enter, and the lymphatics and the bile ducts which leave. In the liver, these vessels undergo a large branching process, and ultimately blood is drained from the liver via the hepatic veins towards the inferior vena cava. We studied about the structure of liver containing 80% parenchyma and 20% stroma. The parenchyma is made up of hepatocytes arranged like bricks in the wall of a building. We described the classical hepatic lobule made up of cords of liver cells separated by sinusoids having a central vein at the center and a portal canal at the periphery, like spokes of the wheel from a central hub. The portal canals we studied, each portal canal, we say portal triad, though a misnomer. It contains a branch of the portal vein, a branch of the hepatic artery, the bile duct tule, as well as nerves and lymphatics. And last we spoke about space of Marl around the vessels in the portal canals. Let's continue with the study of liver histology. The liver is covered by a connective tissue all around called the Glisson's capsule. It's made up of fibroconnective tissue and enters the liver at the hilum to accompany the vessels as they branch and rebranch. Vessels are also surrounded by this connective tissue till the portal spaces. And you get delicate reticular fibers that pass between the liver cells and line the sinusoidal spaces. These reticular fibers support hepatocytes. This is an illustration showing you rows of hepatocytes, and this is the portal area containing a portal vein branch, a bile duct tule. So you see here the bile canaliculi are spaces between adjacent hepatocytes, and they ultimately drain into canal of Herring, which drains into the bile ductule in the portal space. On the other side, you can see the portal vein branch and the sinusoid branching off from it to supply blood between the liver cells. The bile canaliculi are spaces, we said, between the hepatocytes, and these spaces are demarcated and have tight junctions between the edges of the spaces to prevent any leakage. Let's study the hepatocyte. Now, the hepatocyte is a six-sided cell. There is a nucleus in the center, and it has a lot of organelles. Why do you think it has a lot of organelles? It has a high metabolic activity, so it will have a lot of mitochondria, endoplasmic reticulum, Golgi apparatus, lysosomes, stored products like glycogen, lipids and iron. So we have a hepatocyte here, and it is filled with a lot of cell organelles. If we would like to study the hepatocyte further, let's look at the surfaces. So when we say surface, here there is a surface. This surface lines a sinusoid, so that is called the sinusoidal surface, and it is absorptive in function. It makes up 70% of the total surface area of any hepatocyte. Then there is a canalicular surface, the green structures that you see here. These are the bile canaliculi, and the canalicular surface is a secretory surface. It makes up 15% of the total surface area. The rest is called the intercellular surface. It just has cell junctions between the two sides of two cells, and it makes up 15% of the balance cellular surface. So, the hepatocyte has got a sinusoidal surface, a canalicular surface and an intercellular surface. Let's study the sinusoidal surface. We said this is an absorptive surface, about 70% of the surface area. Do you notice these small projections here? These are microvilli. They are finger-shaped projections, and what do? They increase the surface area of the cell for absorption or secretion. This space above them lies between the cell surface and the endothelium of the sinusoid. So, this is called the perisinusoidal space of Dissay. This perisinusoidal space lies between the sinusoidal epithelium and the sinusoidal surface of the hepatocyte. And this space allows plasma flow, and lymph originates in this space and drains into the lymphatics in the portal areas. The next surface we are going to study is the canalicular surface. This is 15% of the surface area. It is secretory. It has depressions on both sides, and there are cell junctions, tight junctions and desmosomes on either side of the canalicular surfaces. These desmosomes and tight junctions maintain watertight closure and do not allow any leakage of the bile secreted into the biliary canaliculus to get out of the biliary canaliculus. Then we have the intercellular surface. This intercellular surface is between two adjacent hepatocytes, makes up 15% of the surface area, and the cells are united together by junctional complexes. Let's take a look at the hepatic sinusoids. So, here we have two hepatocytes attached to each other, and they line the sinusoids. This is the endothelium of the sinusoid. Here we have a special cell called the Kupffer cell and another special cell called the Ito cell. Besides these cells, we just have the endothelial lining of a sinusoid. So, on both sides here is the lumen of the sinusoid. This is the bile canaliculus between adjacent hepatocytes, and this is the space of Dissay that we have just discussed, lining between the endothelium and the sinusoidal surface of the hepatocyte. Now, the endothelial cells that you see here, we see 1, 2, 3 endothelial cells. These endothelial cells are discontinuous. Do you notice they are not touching? So, there is a discontinuous layer of endothelial cells. They are fenestrated, there is no diaphragm and there is no basement membrane. So, what happens now is there is a high permeability, and so exchanges between the hepatocyte and the blood flowing in the sinusoid can take place easier. Space of Dissay, we said, is what we see here, the space between the endothelium and the sinusoidal surface of the hepatocyte. There are collagen fibers running in that space that support the hepatocytes in position. We talk about the Kupffer cell. These are large cells which have vesicles in them. They are stellate shaped and they are the liver macrophages. They are cells for defense. We all know that liver macrophages will always defend. So, all macrophages are cells of defense. So, the liver also has its own macrophage system of cells called the Kupffer cells. These are large stellate shaped cells with vesicles in their surface. You can see the vesicles here. This is the nucleus and they are much larger than the endothelial cells. They remove and destroy any toxic foreign infective material from the bloodstream. Another special cell is the IIT cell. Can you see this cell here with a lot of fat droplets in it? That is why this cell is also called the lipocyte. These cells make up 6 to 8% of liver cells. They were also called IIT cells, Stern-Zellen cells. They are fat storing cells or lipocytes. Today, they are known as hepatic stellate cells, also called perisinusoidal cells. They lie in the space of Dissay between adjacent hepatocytes and they store and regulate transport of vitamin A in the body. So, that is your hepatic sinusoids on both sides. These are the RBCs in the blood sinusoids, the sinusoidal surface of the hepatocyte, the IIT cell in the perisinusoidal space of Dissay, the endothelium, Kupffer cells, and this is the hepatocyte with a sinusoid on the other side as well. Let us briefly go through liver functions. First, it is an exocrine gland secreting bile. It also has a role in metabolism of carbohydrates, proteins and fats, stores glycogen, lipids. It secretes fibrinogen and plasma albumin, protects the body by detoxification of substances like drugs and alcohol, removes bile pigments from the blood, has phagocytosis, and during fetal life in neonatal liver, it is a center for hematopoiesis. After birth, this function ceases. To summarize, bile secretion is done by liver cells into bile canaliculi. Spaces between the plasma membranes of adjacent cells, they have no walls of their own, always remember this. And this drains into the intralobular ductules, interlobular ductules of portal triads. We spoke about the hepatocyte having a sinusoidal absorptive surface, a canalicular secretory surface and an intercellular surface. What were sinusoids? Spaces between adjacent plates of hepatocytes lined by discontinuous endothelial cells having fenestrations, no diaphragm, no basement membrane. Then we said Kupffer cells. These are hepatic macrophages We also spoke about IIT cells and liver functions. We now proceed to the gallbladder histology. Where does the gallbladder lie? The gallbladder is a pear-shaped sac which lies just beneath the liver in the right hypochondrium. It is connected by a cystic duct to the bile duct, and it collects and stores bile. It also concentrates bile and releases it as and when required by contraction into the cystic duct, common bile duct, and ultimately into the duodenum. The bile flows into the duodenum on ingestion of a fatty meal. The fundus of the gallbladder is a part of the gallbladder at the blind end, which peeps beneath the surface of the liver. The body is the main part, and then there is a neck which joins with the cystic duct. The capacity is around 50 ml and it stores and concentrates bile. Let's look at the histological slide of the gallbladder. In a low power view, this is what you see. Now, classically, when we describe the gastrointestinal tract, we always talk about 4 layers. Which are those 4 layers? Mucosa, submucosa, muscularis and adventitia. But remember that when we talk about gallbladder histology, we have only 3 layers: mucosa, the muscularis and the adventitia. So, in the gallbladder, there is no submucosa. It is just 3 histologically different layers. Let's take a look at these layers. The innermost is the mucosa. You see an epithelium and it's highly folded. These folds are called rugae. The next thick layer that you see is the muscularis propria. The outermost is a thinner layer which is called the adventitia. So, there is a mucosa, a muscularis propria and an adventitia. There are only 3 layers, unlike the gastrointestinal tract. There is no submucosa. Let's take a higher power view of the gallbladder at the mucosa. The mucosa is very thin. It is the thinnest of all the layers. You see it extends till here, and then you have the muscularis from here onwards. The mucosa is highly folded into folds called rugae, especially when the gallbladder is in an empty state. The lining is a simple columnar epithelium with a brush border, and the folds can branch and anastomose with each other. There is something called sinuses of Rokitansky and Aschoff. These are invaginations of the epithelium into the underlying muscularis. When there is excessive folding, the folding can even extend into the muscularis. Another slide here showing you the columnar epithelium lining the mucosal side, and these are the invaginations into the underlying tissue that you see here, and these can be called the Rokitansky-Aschoff sinuses. This is the muscularis and that is the adventitia. On electron microscopy, the mucosal cells, which are tall and columnar, have microvilli on the surface and there are tight junctions between cells. The basal side of the plasma membrane has infoldings and bile is concentrated by water absorption and water passes into the underlying lamina propria. The neck of gallbladder is a special mention because this neck has a special valve called the spiral valve of Heister. This valve is a mucosal fold, spirally shaped, and the core contains smooth muscle fibers. This valve will prevent sudden changes in the capacity of the gallbladder due to changes in pressure. What about the remaining layers? So, we are talking about now the muscularis. This muscularis is made up of bundles of smooth muscle fibers, in between which you will see collagenous, reticular as well as elastic fibers. Outermost is a thin adventitia. It could even be a serosa, depending on whether there is an epithelial lining or not. There is dense fibroconnective tissue, could be a lining of mesothelium, and in some places this adventitia blends with Glissen's capsule of the liver. We proceed to the pancreas. The pancreas is also an exocrine and endocrine gland lying on the posterior abdominal wall from the right to the left side. It has a head, a body and a tail, and the head lies in the C-shaped concavity of the duodenum. The pancreas has an exocrine part which secretes pancreatic juice into the pancreatic duct, which joins the bile duct to open in the duodenum. It also has an endocrine part which has special cells producing substances like insulin and glucagon. So, it has an exocrine part and an endocrine part having two different sets of cells producing these two different functions. The gland has a capsule around it, a very thin areolar tissue which sends septae into it, giving you lobules. The acinous cells in the pancreas can produce pancreatic juice of about 1.5 liter per day. Looking at a histological slide of the pancreas, under the lower power view, we see glandular tissue, darkly stained. These are the lobules. This is the interlobular connective tissue that you see here, and you see pale circular shaped areas in between. These are the islets of Langerhans which make up the endocrine part of pancreas. So, these are the endocrine parts, whereas the rest of pancreas is the exocrine part made up of acini draining into a duct system. The exocrine part produces digestive enzymes for digestion of carbohydrates, proteins and fats. The endocrine part produces hormones like insulin and glucagon, and these are carried by the bloodstream to the liver, where they influence metabolism of carbohydrates, proteins and fats. You can see the gland here, the lobules. It's a serous compound tubuloalveolar gland having a delicate capsule outer which surrounds the gland and sends septae into the gland, dividing it into lobules. An illustration of these acini and the islets of Langerhans, and these are the duct systems. The secretory element is long, it's tubular, it's surrounded by a basal lamina. There are triangular pyramidal serous cells surrounding a lumen. Each cell is pyramidal in shape, having an apical side with granules in it called zymogenic granules. They are eosinophilic, and a basal spherical nucleus. The rest of the cytoplasm is basophilic except the granules, which are eosinophilic. In the lumen of the acinus, some of the cells of the intercalated duct extend to give you the centroacinar cell. The centroacinar cell is not a true cell of the acinus, but it is cells of the first part of the intercalated duct that lie at the center of the acinus, and so they are called the centroacinar cells. What are the secretions of an exocrine pancreas? The first is a watery secretion, very rich in bicarbonates, neutralizes the acid contents of stomach entering duodenum. The second type is a thick secretion containing enzymes like trypsinogen, chymotrypsinogen, amylases, lipases. You get other amines like gastrin or vasoactive intestinal polypeptide also secreted by exocrine pancreas. Secretion is by exocytosis, but these secretions are inactive in the pancreas. They activate only once they mix with duodenal contents. So, pancreatic enzymes cannot take any action on the pancreatic tissue itself because they are inactive when they are secreted, and they become activated only when they combine with the contents of the duodenum. Let us talk about the duct system of the exocrine pancreas. There are the intercalated ducts, which are the smallest intralobular ducts. These drain into the larger interlobular ducts, which ultimately drain into the main pancreatic duct. The intercalated ducts have a flat cuboidal epithelium, initially squamous and cuboidal as it starts draining into the interlobular duct. The epithelium then turns into a columnar type of epithelium. The cells of the ducts control bicarbonate and water content of the pancreatic secretion. What are differences between the pancreas and the parotid? So, the exocrine pancreas and the parotid gland. Parotid is a salivary gland. It is a serous type of gland and can look very similar to the pancreas exocrine part. But there are differences. For example, in the parotid gland there are striated ducts. There are no striated ducts in the pancreas. In the pancreas there are islets of Langerhans. There are no islets of Langerhans in the parotid. The centroacinous cell present in the pancreatic acinus is also absent in the parotid gland acinus. So, these are some of the differences between the parotid gland and the exocrine part of pancreas. Let us talk about the endocrine part of pancreas. If you see on a high power view of a pancreas slide, you see these paler staining isolated collections of cells surrounded by the exocrine acinar cells. These are called the islets of Langerhans. There are about 1 million islets in the human pancreas. The islets of Langerhans are most numerous in the tail of pancreas. These islets, you notice, they are called islets like islands. They are like small islands surrounded on all sides by C. In this case, the C is the acini of the pancreas. These islets of Langerhans have endocrine cells and they have capillary plexuses between the cells arranged as cords or groups. And the cells of the islets belong to the gastroenteropancreatic endocrine system. These islets are very rich in autonomic nerve supply and are under autonomic nervous control. Let us take a look at what cells you get in the islets of Langerhans. The A cells. The A cells are 15 to 20%. They are placed peripherally in the islet and they secrete glucagon. These are also called alpha cells. Next are the beta cells. Beta cells are also called the B cells. They are most numerous, 60 to 70%. They are mostly placed in the center and they secrete insulin. Now, all of us know what is insulin. It is the secretion required to bring the sugar levels down, and this insulin is what is very vital to a diabetic patient. So, this insulin is secreted by the beta cells or the B cells of the pancreatic islets. Next are the D cells or delta cells. They are less in number, 5 to 10%, also placed at the periphery, and they secrete gastrin, somatostatin, which inhibits glucagon and insulin secretion. So, these gastrin hormone is going to influence the above two secretions. The PP cells or pancreatic polypeptide cells are very few. In the head and neck of pancreas, they secrete pancreatic polypeptide. The D1 cells again are very few and they secrete the vasoactive intestinal polypeptide. A few other unnamed cells secrete serotonin, mortellin and substance P. So, the most numerous cells in the islets of Langerhans are the alpha cells or the A cells, the beta cells or the B cells and the delta cells or the D cells. The alpha cells, I told you, secrete glucagon. The beta cells secrete insulin, which is very important in diabetic patients. Let's look at an islet of Langerhans. Now, this is the islet of Langerhans with a special stain called Mallory-Azan stain. This staining is done to identify the types of cells from each other. The red cells that you see here, these are the alpha cells which secrete glucagon. And in between you can see some bluish colored cells. These are the beta cells, more centrally placed, which secrete insulin. The D cells are also peripherally located and the other fewer cells cannot be identified individually. You can see blood spaces or capillary spaces between the groups of cells, and this is the periphery of the islet. And here we show you the islet surrounded by well stained pancreatic acinar cells. So, these are the pancreatic acinar cells. That is your islet of Langerhans, the periphery. This is the red stained glucagon secreting alpha or A cells, and you can see the bluish beta cells secreting the insulin. Pancreas, being an endocrine gland, also has a rich arterial supply from the celiac artery and the superior mesenteric artery. Venous drainage is into the portal system. The vessels run in the interlobular connective tissue and finer vessels run intralobularly. The arterioles go into the islets, break up into capillaries, and endocrine secretions get into these capillaries. The blood from the islets then passes into the exocrine part. So, the hormones which are poured into these capillaries can now influence the exocrine part. Autonomic nerve supply comes from the celiac ganglion and the vagus, and the autonomic nerves influence pancreatic secretion. To summarize, the gallbladder, we said it's a pear-shaped sac draining into a cystic duct having the fundus, body, neck and a capacity of 50 ml. Stores and concentrates bile which is discharged into the duodenum, and the wall has 3 layers. Remember, no submucosa, just mucosa, muscularis propria, adventitia or serosa. The mucosa I showed you was highly folded, having rugae, lined by tall columnar cells having a striated border and basal nuclei. The folds can branch in anastomose and even invaginate into the muscular layer, giving you sinuses of Rokitansky and Aschoff. The pancreas we studied is exocrine and endocrine gland, having 2 different functions by 2 different cell types. The gland has areolar tissue which give you septae going into the gland to form lobules. The exocrine part is secretory. It's got long tubular secretory acini surrounded by a basal lamina having triangular or pyramidal serous cells surrounding the lumen. A spherical basal nucleus, there are centroacinar cells. All this drains into the intercalated duct. This drains into large interlobular ducts and ultimately the main and accessory pancreatic ducts. There is an increase in height gradually from squamous to the smallest duct, to cuboidal and then columnar in the largest ducts. Ductal cells are important. They not only contain the secretion, but they also control bicarbonate and water content of pancreatic secretions. Then we talked about the endocrine part, which is made up of the pancreatic islets, also called islets of Langerhans, about 1 million in number in the pancreas, concentrated mostly in the tail and separated from surrounding acini by reticular fibers, and they have rich capillaries, plexuses within them into which the hormones are secreted. Let's talk about some of the clinical anatomy of liver, gallbladder and pancreas histologically. Liver can undergo many diseases. The first and very common one is hepatitis. Hepatitis is nothing but an inflammation of the liver caused by viruses A to G, or the Epstein-Barr virus, herpes simplex virus, cytomegalovirus. Even amoeba can cause hepatitis and give abscesses in the liver. This is a slide showing you liver cancer. You can see there are tumor masses growing within the liver tissue. They have even invaded the portal vein branches. This is called hepatocellular carcinoma and could be of two types. It could be a primary type or it could be a secondary type. When we say primary, it means the cancer originates in the hepatocytes. When we say secondary, it means the cancer comes from elsewhere into the liver as a secondary metastasis. Metastasis is commonly arising from lung, colon, pancreas and breast. Excessive alcohol consumption. This is a common problem nowadays and it's very toxic to the liver because it damages the liver cells. It causes a lot of scarring, fibrosis and inflammation. Hepatocytes accumulate a lot of fat and they get distorted and distended. Another disease is cholestasis, which we commonly call jaundice. All of you must have heard of jaundice. What is it? It's a disease in which the liver is affected and you get a yellowish discoloration of the sclera of the eye and the skin of the body. There is reduced bile formation or flow leading to high levels of bilirubin in the body, leading to jaundice, which is the yellowish discoloration that we see, I said, in the sclera and skin because of excess bilirubin circulating in the body. Cirrhosis of the liver. Some of you must have heard of this. This is end stage of chronic liver disease, usually due to alcohol consumption or biliary obstruction or even viral hepatitis. Hepatocytes are destroyed, they are replaced by scar tissue or fibrous tissue. The normal architecture of liver is collapsed. It is totally destroyed, it cannot regenerate from this. It leads to disruption of the blood flow in the liver and resistance to the flow, leading to a condition we call portal hypertension. So the portal vein which drains into the liver can no longer drain easily because of scarring and fibrosis, and the pressure in the portal vein increases, and this leads to many more complications. Destruction of hepatocytes causes liver failure. Waste products accumulate in the blood. This leads to unconsciousness, ultimately hepatic coma and death. So chronic liver failure, cirrhosis, can ultimately lead into hepatic coma and death. This shows you how complicated liver diseases could get. Coming to clinical anatomy of the gallbladder, the most common clinical aspect is the accumulation of gallstones. So here you see there is a large stone in the upper portion here, whereas in the lower part you can see small faceted stones of much smaller size. You notice another thing, there is a thickening of the wall of the gallbladder. So there is inflammation of the wall as well as accumulation of stones in the lumen. The stones are solid deposits of cholesterol or calcium salts, and they are important because they can block the duct system. They can block the bile flow, causing biliary colic and jaundice. They can also cause inflammation of the wall of gallbladder with thickening, and all this is called cholecystitis. So, cholecystitis is an inflammation of the gallbladder wall. Cholelithiasis is stones in the gallbladder or the biliary tract. Cholelithiasis usually has to be treated by surgery. So, you do a surgery and you can remove the gallbladder or you can remove the gallstones. This procedure is called a laparoscopic cholecystectomy. Coming to the pancreas, this pancreatitis, it could be acute or it could be chronic. Usually due to alcoholism, there is inflammation of the exocrine part, and this is called acute pancreatitis. Then there is chronic pancreatitis. When you have repeated episodes of pancreatitis, it leads to chronic pancreatitis. There is inflammation, there is irreversible functional impairment of the gland, usually due to chronic alcoholism or smoking or cholelithiasis, that is gallstones. There is fibrosis of the parenchyma, there is cyst formation due to dilatation of the intralobular ducts, and there is a destruction of the islets of Langerhans. So, there is a destruction of the tissue, destruction of the duct system, destruction of the islets, and fibrosis or scar formation in chronic pancreatitis. Let's summarize our topic for today. We have talked about the liver, its lobes, right and left, caudate and quadrate. A large blood supply, about 25% of the blood in the body flows into the liver at any given time. The celiac artery brings in oxygenated blood. The portal vein brings in blood from the gastrointestinal absorbed products of digestion. It drains into the inferior vena cava. The porta hepatis is the part on the inferior surface of liver where portal vein, hepatic artery and nerves enter, and the hepatic bile ducts and the lymphatics leave. We studied a classical hepatic lobule, which is hexagonal shaped, the structural unit of liver, made up of cords of hepatocytes separated by sinusoids, having a central vein in the center and the cords of cells radiating like spokes of a wheel from a central hub to portal canals at the periphery. Portal canals containing branches of portal vein, hepatic artery, interlobular bile duct as well as lymphatics and nerve plexuses. We studied the hepatocyte, the basic liver cell, polygonal, having a sinusoidal surface, canalicular surface for bile canaliculi and the intercellular surface between adjacent hepatocytes. Then we studied about the gallbladder, the fundus of the gallbladder, body and neck, the wall of the gallbladder different from the gastrointestinal tract because it has only 3 layers, a mucosa, a muscularis and adventitia, no submucosa. The mucosa thrown into rugae, tall and columnar epithelium with striated borders, basal nuclear cells with folds that may branch in anastomose giving you sinuses of Rokitansky-Aschoff. We also studied about the pancreas, the exocrine part made up of acini having centroacinous cells draining into intercalated ducts, interlobular ducts and the pancreatic ducts. The endocrine part made up of the islets of Langerhans, about 1 million in a pancreas, concentrated in the tail. In clinical anatomy, we covered hepatitis, liver carcinoma, cirrhosis, cholestasis, cholelithiasis or gallstones and acute and chronic pancreatitis. With this I end my topic for today. Thank you.